Today's talk will be about the magic of ultrasound physics. We'll talk about 4 important topics in regards to CLUE, which will be 1, is ultrasound safe? 2 is how a beam becomes an image. 3, Harvey's, quote, big mistake, which affected the field of echocardiography and orientation. And finally, artifacts, specifically CLUE artifacts that you need to know. And after this talk, you'll feel like you've gotten a massage, seen some good art, and been to a magic show. So this slide conceptually talks about wavelength and frequency. As the wavelength gets shorter, the frequency gets higher, as you can see by compression of that waveform. Now if we add to this concept of ultrasound, we begin to see where audible sound is, ultrasound is, radio, microwave, infrared, visible light, ultraviolet, and X-ray in this conceptual diagram. But let's focus a little bit on ultrasound. Acoustic sound is what we can actually observe, higher than what we can hear, certain animals can hear. And then finally, when you start hitting the ultrasound range, the lower end of that range can be used in therapeutic ultrasound. But finally, when you get to around the 2 megahertz or greater range, you begin to get what we consider diagnostic ultrasound. And people began to bring up this question of how can you have therapeutic ultrasound at a slightly lower frequency, and yet echocardiography or diagnostic ultrasound is considered totally harmless. But is it? So let's look at this. Let's look at a 20-year-old male here presenting with dyspnea. This is transesophageal echo images where 2 masses are seen in the right atrium. You can see them there. They're clot attached to the wall of the superior right atrium. There's a small pericardial effusion there. And then something happens during this transesophageal echocardiogram, and it's quite profound. And you see embolization of one of the masses. This patient survived, by the way. Proof of that is we went back and looked at where the superior masses were, and there was only one left. Another case. This is a case of a 50-year-old who had an aortic valve Staph aureus endocarditis and persistent bacteremia. And on probe insertion, you can see there this very mobile vegetation attached to a tricuspid valve in the right atrium, prolapsing into the right atrium. But 5 seconds later, when going back to look at that for a better look at it, it's now gone. There's a little remnant of it on the tricuspid valve. If you looked, the stalk is still attached, but the major portion of the vegetation has embolized. Is this coincidental that this was going to happen anyway, or was this the ultrasound application that vibrated this mass loose? Here's another interesting case. Here's a case, not of a vegetation, but this time of an echo being performed at the bedside in the ICU for ejection fraction. And during this examination, what you see is there's mitral regurgitation, and then suddenly, you can look at the telemetry, the patient codes. Now we're in polymorphic VT. Interestingly, you still have the mitral regurgitation despite the VT, and the patient had just undergone osteo-LED stenting and had an acute anterior myocardial infarction, which was complicated during the echo by VT-VF, and the patient was successfully resuscitated. One wonders whether or not the timing on this it was important, whether the ultrasound itself was pro-arrhythmic. We want to talk a little bit about transducer frequency. The lower the frequency, the more penetration, but the less resolution that you have. And you can kind of remember this, that the bass is something that you always hear through your neighbor's wall because it has such low frequency, it penetrates, where the higher frequencies delineate the structures much better, have better resolution. And when we think about these bioeffects of diagnostic ultrasound, it is like getting a massage. Ultrasound heats the tissue. We have what's called a thermal index, the representation of ultrasound power necessary to raise tissue temperature by 1 degree. It vibrates tissue, so a manifestation of ultrasound power in what's called a mechanical index, and it can cause cavitation. And then finally, clinically, we take advantage of these bioeffects of diagnostic ultrasound by doing ultrasound-facilitated thrombolysis. Here is a study called the CLUEphysicswebinar trial, where 2 megahertz, this is in the diagnostic range, using transcranial Doppler, helped to recanalize stroke victims' middle cerebral artery using transcranial Doppler and after having received TPA. You may see this more recently manifested in treatment of pulmonary emboli, where we put in an ECOS catheter with 3 transducers there that emit low power, 2 megahertz frequency, and help lysis of pulmonary emboli. So that was a brief run about what the mechanical and thermal effects of ultrasound and whether it is safe. So now let's move to the second part of it, is how does a beam become an image? This is a little complex. We're going to go through in a whirlwind way of how an ultrasound image is made. So it starts traditionally with a crystal, quartz, or ceramic called a piezoelectric crystal, pressure piezo to electricity. What happens is if you apply a current to it, it emits a frequency of ultrasound. We'll liken it to a bell, where the electrical current is ringing the bell, striking the bell, and creating a sound. This electric crystal can be arranged in an array, as in this diagram here, where you can phase this array in a transducer, and by phasing it, you can focus the beam and obtain better images. Now, I'm talking about a phased array transducer. There were mechanical array transducers, which was one single crystal that was moved and took images as it moved. So the transmit gain, one of the knobs on your standard echo machine, but not on your pocket-sized devices, the transmit gain increases the voltage, rings the bell harder, and therefore gets a brighter image simply because it emits a more powerful signal. The probes themselves have been designed with a frequency and a shape in mind, so that, for instance, the cardiac probe is set so you can get intercostal between the ribs. The abdominal probe, which is a higher frequency, the crystals are aligned in this curvilinear pattern so that you can image deep into the belly without having any sharp edges. And then finally, a vascular probe is flattened or linear in its arrangement of crystals, so it can give you a view of flat surface structures, such as vascular images of the carotid or of the veins. Bandwidth and center frequency are reported for CLUE. It is between 4-2, which is 4 megahertz, to 2 megahertz as a bandwidth with a center frequency of 3 megahertz. So you'll see these ultrasound transducers labeled as 4-2 or 7-3, and these are all the representation of the bandwidth, with the higher frequency by convention listed first. There's 2 concepts you need to know about, which is the axial resolution and the lateral resolution. The axial resolution is seen here in the yellow dots, and it's partly dependent upon pulse length. The lateral resolution becomes difficult as the beam begins to spread in the far field of the image. All right, back to what you get off that single transducer. Pretend you are monitoring a single crystal in this phased array, and you've just hit it with an electrical impulse. This is the reflected wave back. This is the echo that you get from the target that you're imaging. So the RF signal comes back, and then we can bump up what's called the receiver gain. So this is not hitting the bell. This is not the transmission gain. This is the receiver gain. This does not add any more power to the tissue. This is just listening better. So the receiver gain, we use TGCs, time gain compensation. Now, on your devices, they are already been programmed, but on a full machine, you can boost up the signal in the far field to account for attenuation so that the image looks consistent throughout its depth. So through TGCs, we change our RF signal so that you don't have the natural loss in voltage due to attenuation We amplify this RF signal, we rectify it, compress it, and filter and envelope detect it. And once you do, and fit it into a dynamic range of about 30 decibels, you end up with a polar signal, which is all positive, which you've assigned now through post-processing 30 to 50 shades of gray. And that's the post-processing curves that are inherent to each of the protocols that you select on your devices. So if you want the cardiac protocol, or if you want the abdominal protocol, or the OBGYN protocol, or the linear protocols, the companies themselves have selected optimal post-processing curves to visualize those structures. In the standard machines, you can adjust them yourselves. You can choose between different post-processing curves. But on the point-of-care devices, it's simple enough to automate that. Well, you get this polar signal now, and it now is represented by one line, one scan line of gray. So instead of these peaks and valleys, you have blacks and whites, and those black and whites create one scan line of data, and that one scan line of data is shown on the screen. And then you collect many, many scan lines, because as I said, that was one crystal, and now you're going to have an array of crystals to create an image. Now, of course, that would be great to have an infinite amount of crystals, but of course the processing time and the ability to await the return of the ultrasound from the far field limits how many you can have in a moving target like the heart. And this has to do with what we call frame rate, waiting for the ultrasound to come back through each of those crystals in order to produce an image that is updated. So here's one of 128 scan lines that you can get onto this image. And as you can see, as you make this, it'll create an image where the far field is a little bit more interpolated. The data between the scan lines is not real data. In this image, the dot on the top of the screen, which is very important for you to know about, is the orientation dot that relates to the directional marker, usually a ridge, on the probe itself. We talked, here's an example of that. We talked a little bit about the frame rate and depth, and how frame is interwoven. Two fields are interwoven into a frame. This is all video production. Just a quick update in 2018 that are important to the point-of-care ultrasound field is that this concept of the piezoelectric crystal has been challenged by the company that has made the butterfly, is what they call it. This is the transducer attached to an iPhone. It works through what's called CMUT on CMOS, which is chip technology to create an ultrasound transducer, which reduced the price. The other update is the wire that connects the transducer probe to the phone itself through a different company has been able to be eliminated, and you essentially Bluetooth your image over across to your screen. All right, so we got through the hardest part of this talk, which is how a beam becomes an image. We're now going to talk about what I like to tongue-in-cheek say is Harvey's big mistake. Harvey Feigenbaum is the recognized father of echocardiography. And here he is in a room full of ultrasound and electronic equipment in order to create what was called an M mode of the heart. Now, an M mode of the heart is one single beam, one scan line from one crystal on a transducer. And what they had to do is simply create what was called an M mode. M was for motion, because it was able to, since it's only one beam, it was able to interrogate one region very quickly, because it only had to wait for one beam to come back to the transducer, not 128. And for that reason, even today we do M mode when we want to see something that's moving quickly and characterize its motion, such as the valves opening and closing. And what would happen is they would place their probe to know they're in the right position at first in the valves. And you can see here the aortic and mitral valve in this M-mode recording that came out of the chart recorder was seen first, and then they panned down toward the apex. So when you create an image from this M-mode, one would see it would look like this. You would have the aorta and mitral valves on the right and the LV on the left. So when Dr. Feigenbaum was asked to postulate what a 2D image would look like from an M-mode as he developed 2D ultrasound, 2D echocardiography, he figured it would look like this from the peristernal long axis view. And that's not that far from what we end up having. So now you can see why C, B, and A correspond to the way it came out of the chart recorder. And because of that, we have a image where the peristernal long axis is actually flipped. Here we have peristernal long axis view, but yet the apex is to the patient's right and the aortic and mitral valves are to the patient's left, which is not anatomically correct, but it's the way it came out of the M-mode. And to my understanding, this is the way we accepted it, and this is how echocardiography is performed across the world. So here's a subcostal view, oriented correctly. It's the peristernal long axis view that's flipped. Now let's flip the peristernal long axis view, and there you have it. It looks a lot like a more cephalad view of the subcostal view. The RV and the LV are in the right positions, except when you go peristernal, you get the aorta, where subcostally you'd have to angle up to get that aorta. So there's the rub. The rub is that we're flipped in the peristernal views. It's a mirror image. And take note that the directional marker is on the opposite side of the convention that you see in radiology. I think when you go to a machine, the best thing to do is hold your standard clue grip, as you've seen in prior videos, and stare down the barrel of the probe and be sure that the directional marker on the probe is on the same side as the directional marker on the screen. And when you do this and use your same hand positions that you've learned, you will always stay in the clue format. If you just haphazardly put it on the chest, you will have to figure it out as you image. And that's sometimes hard to do if your first image is difficult to get. Alternatively, you can try to learn each unknown machine you walk into and try to set it up deep in its programming of how to orient the image. So if you do come up to a machine that is set in a radiology or ER mode, put that directional marker essentially not toward the right shoulder in the peristernal long axis view, but towards the left hip in order to get an equivalent peristernal long axis view as when it's in the cardiology mode. Suffice to say, look down the barrel of the probe, match it to the screen, and use the same hand position. You'll get the proper result. Here I am many years ago with Dr. Feigenbaum, and I actually asked him and got the history behind the last two slides you've seen. And very humbly, he said, you know, if this is the worst mistake that we made pioneering this, then he feels relieved. He's certain that there are far more important errors. Okay, we're talking now finally to the important part of clue artifacts that you need to know. And this will be a magic show. There are going to be some common clue illusions here. And the basis behind these illusions are going to be that ultrasound has three things it can do. It can either attenuate through the tissue, in other words, as it hits the tissue, it starts to lose power as it penetrates. And that's partly because when it hits these structures, some of the ultrasound beam's power is scattered or reflected backward, leaving less to go deep within the image. A lot of these phenomena that you're going to see are due to edge effects. For instance, is there a plaque here? Yes, there is, because this is a carotid artery. You can see two areas of shadowing where the plaque, calcific plaque, bright plaque, has attenuated the beam and reflected the beam so much that there's no power left to image the far field. But is there a plaque here? You can see along this edge or lateral wall of this transverse image of the carotid that there is dropout, and what's called an edge effect. And this edge effect is due to loss of power going through that wall is causing a lower amount of ultrasound available to the distal structures below that wall. Conversely, if you go through the dark areas of both these vessels, you don't lose much ultrasound power, so you have posterior enhancement or lack of attenuation deep to those vessels, just as you do in a simple cyst. Next artifact I want to talk about is the reverberation artifact, and this is the infinity mirror effect, where a beam is basically stuck between two reflectors and just bounces to infinity back and forth. Here in the lung, the common A-line artifact is a reverberation artifact because it's reflecting off the pleural surface and the probe itself. And here's an example of this. The beam comes out, hits the pleural surface, creates an echo that we know back to the transducer. We know that, but the second line is, of course, not anticipated. And what it is the beam then bouncing off the transducer and going back to the pleura for a second artifact, which is then enhanced because of TGCs. The key here is that 1x, 2x, 3x are the distance between the transducer and the pleural line. Well, when you think about it, the common tail artifact is a form of reverberation itself, where it's postulated the beam penetrates either a thickened pleural structure and just reverberates within that pleural structure, whether that's thickened fibrotic septae or a bubble tetrahedron, as in this image. The beam gets stuck, keeps bouncing around, causing a ring down artifact, which is a form of reverberation. Here's an example of how the signal, in this case, is multiplied by multiple x's, not just one x, but 50 x's here between these lines. All right, another artifact I want you to look at it. Let me ask you a question. Do you think there's left atrial enlargement here? And the answer is there is left atrial enlargement here, but if you look at the wrong line that is bisecting the left atrium, you will be fooled and say that the left atrium is normal in size. The left atrium actually goes all the way back to that descending aorta that you can see in the far field. So why does this artifact appear to trick you to think that the left atrium is normal? Well, that's the right atrial border with the right atrial pericardium that's projecting as a bright side lobe artifact within the peristernal long axis view. And this is what we call a side lobe artifact, and I'll show it to you in the next slides, but this is a concept that we're all familiar with in Pepper's Ghost at Disneyland. When you ride the Haunted Mansion, this ghost, which is in another room, reflecting off a glass, can be projected into your cart as an image. Well, a side lobe artifact, in a sense, is a lot like that. Here's one of the right atrial, right ventricular view, where very bright, and that's key, it has to be bright, a bright pacing wire is seen in the right ventricle, and if you tilt and then move to the peristernal long axis view of the left heart, that right ventricular pacing wire gets projected as a yellow arrow in the left ventricular outflow tract, obviously at the same depth that it was in the right atrium. So why does this happen? Well, here's the beam that you want to get information from, but as an artifact of ultrasound, you send out side lobes from this beam. It's unavoidable. If these side lobes of this beam interact with a super bright green, as seen here as a green circle, super bright target outside of the area that you're imaging, it will reflect and send back a signal that the computer will think is just slightly shorter, depending on where it is. It will place it as if it's in the same plane as the red circle. In this case, it's a little bit shorter, so it puts it in front of the red circle. Well, in the image of the left atrium, the right atrium has an artifact which is seen by the top yellow arrow, And that's not even in the plane that you're imaging, but it's so bright that it gets reflected, just like the green target, into the main image. And it will fool you to think that the left atrium is normal. All this really tells you is that the left atrium is larger than the right atrium, and because of that, the right atrial border gets finally projected into the left atrium. Usually they are the same size and they are projected overlapping each other in the deeper arrow. One more artifact to talk about is the mirror artifact, and we see this a lot looking for pleural effusions. Here is a liver. This one here is set up in the radiology standard where head to the left, feet to the right. The diaphragm is seen as a linear density over the liver. And then in the what should be the pleural cavity side, one sees what looks like liver. And this is the mechanism of how this happens. But notice on that image how you can't see through the image to see deeper structures such as the spine. Well, here it is in real life. Now we image like we talked about in the earlier slides, head to the right, feet to the left, CLUE and cardiology standard. And here is an example of the mirror artifact. And there's not liver in this pleural cavity. And notice how the spine, which is this corrugated deep structure in the far field, just cuts off there halfway through the screen, and then you encounter the artifact. Now the image on the right shows that the spine is completely through the image, and you do have, in this case, consolidated or atelectatic lung, and it's not a mirror artifact. And what's important here is that the spine can be seen going across the field. That's true data because you're getting it all the way back to the spine. Or on the left, that data is bogus because you can't see the far field. Oh, that's essentially it. This is your physics lecture. We will see you at the next CLUE lecture.